So now introducing our speaker, Professor Miles Prince. Professor Miles Prince is an experienced haematologist and is the lead clinician at Precision Haematology Epworth and the director of blood cell therapy at Peter MacCallum Cancer Centre. He is also a board member of the Myeloma Foundation Australia and teaches at both the University of Melbourne and Monash University, so is the perfect person to give us a seminar on multiple myeloma. Thanks, Miles. You can start.
Terrific. Thanks, Gabriel. Look, it's a real pleasure to be here. I'm under strict instructions to stick to time, which I'm a time stickler, so I'm going to go through this presentation fairly rapidly, but I'm certainly very happy if you want to get the slides or convert it to PDF or whatever you'd like to do, so that you could, if they want to be distributed. This is actually the format that I use when I'm teaching the College of Physicians trainees as they're working up for their Part 1 exam. So don't get distressed if it's at a level that you think is too high. But it's pretty up to date, and hopefully will give you a good perspective of where we are in the field of myeloma. So I'd really recommend that you go to the Myeloma Australia website, which is a foundation I'm on the board of, and there is the Australian Myeloma Guidelines. So it's available for people. There's no membership, so you can just go to those and you can see a whole series of videos, but also specific guidelines which I'll be addressing. So today I'm going to talk to you really about a few aspects, but talk a bit about the background of myeloma, the investigations, overall treatment, and some aspects of supportive care. So I just want to give you a history, a little case report, which I'll come back to at the end. But I thought the easiest way was to pull out one of my recent letters on a patient of mine. And I'm not going to go through the details of all of this, except to say that this is a woman who's in her early 60s, but she was diagnosed with monoclonal gammopathy of undetermined significance 17 years ago. She then actually, so that was MGUS in 2003. And then by 2006, she actually developed multiple myeloma with the development of bony disease. And at that time, she was treated with thalidomide, which was only 6 or 7 years old. And it was moving, as we were moving away from chemotherapy. So she was treated with a thalidomide-based regimen for a few months, and then went on to transplant using high-dose melphalan, and had her first stem cell transplant in June of 2007. So that's 13 years ago. This was done actually in Sydney, and she came down to Melbourne. And then she developed a slow rise in a paraprotein 2 years later. And that's pretty typical. About 2 to 3 years post-transplant, the disease starts to recur. But interestingly enough, it actually took some time for her disease. It took almost up to 2016, almost 2017, for her to develop her second level of progression, which is quite a long time. And her paraprotein actually climbed up very quickly then, up to 70 grams per litre, which is high, with hypercalcemia, heavy bone marrow infiltrate. She had an abnormality of her chromosomes, a 1q abnormality. Then she was treated with this conditioning regimen called cyclophosphamide, bortezomib, and dexamethasone, otherwise called Cybord-D. And then in February, that was for a few months. And then she had about 4 months of this Velcade-based regimen. Her paraprotein came from 70 down to 19. Her plasma cell infiltrate came down. She went on to some cyclophosphamide. Then she actually had a second stem cell transplant with high-dose melphalan. And she went on to some maintenance treatment with thalidomide. And then a couple of years later, she developed progressive disease again. And she was treated with a chemotherapy regimen called D-PACE, which is an aggressive regimen. Her paraprotein fell quite quickly. And then she had progressive disease again. And then she actually had her third transplant to sort of control her disease. And it's around this time we're starting to get a number of the newer regimens available. And she was trialled on lenalidomide. but unfortunately she developed plasmacytomas and obstruction, and it almost started developing to a soft tissue type disease, and she was commenced on pomalidomide. So she'd had a Velcade, then lenalidomide, and then pomalidomide, which is a lenalidomide derivative, she's then also commenced on a new drug called daratumumab, which is an anti-CD38 monoclonal antibody. So this woman has had the gamut of treatments over a long number of years. She's developed some complications. Carfilzomib we tried at one point, but after one episode she developed a microangiopathy, a TTP-like syndrome needing plasma exchange. She's developed pulmonary embolism, which is common association with some of the IMiD drugs that we use. She's also been immune suppressed and developed things like herpes zoster along the way. So she's actually still going pretty well on the pomalidomide and this new daratumumab. And so she's been a lucky lady in some ways, in that as the new drugs have become available, she's been able to have access to them. So I'm going to come back to that along the way, but it sets the scene for some of the treatments that I'm going to talk to you about. So this, one of the most common questions is, what's happening with myeloma? Is it increasing, decreasing? We know that diseases like non-Hodgkin's lymphoma is increasing. Particularly follicular lymphoma is increasing. We know that other conditions like Hodgkin's lymphoma is not really changing, but myeloma is increasing, albeit slowly. But when you measure it, when you take into context the aging population, it's actually relatively flat. It's a disease that's relatively new. It's a disease of the Industrial Revolution. It really has taken off since the Industrial Revolution, which suggests that there may be some aspect of exposure, which I'll come to. So it is going up because of the aging population. It is going up because we are doing more testing. And one of the questions is it changing because of a definite ethnic mix in Australia? And I'll come back to that. But if you accept age, it's probably not increasing or increasing very slowly. And so if you look at this map here, you can see the incidence in Australia really leads the world. It's got a high incidence in Black African population. It is the most common blood cancer in Black Africans. So it is actually common in the United States, but also common here in Australia. You can see it's not that common in Asia, but actually relatively common around the Mediterranean basin. So then we don't know why this is the case, but we recognise that there may be a mixture of hereditary genetics and possibly some forms of exposure. So in fact, if you look here at myeloma, amongst Black Africans, whether that be in South Africa or in the United States where we have data, it's the most common blood cancer, followed by non-Hodgkin's lymphoma. If you look in whites though, diffuse large B-cell lymphoma is number one, then plasma cell neoplasms, then CLL, then plasma cell neoplasms. So the incidence is about 5 per 100,000. It's slightly more common in males. It has an increased incidence in agricultural workers. We don't know why. Perhaps it's pesticides. There is some association with radiation exposure. There was a lot of activity around benzene and people working with benzene, particularly people in the airline industry. But it's borderline. And obesity, there is a definite association. So when we look at myeloma under the WHO classification, it sits under the mature B-cell neoplasms, which includes what I've really been talking about, plasma cell myeloma. Then there's this solitary plasmacytoma of the bone. And then there's this relatively rare condition called extraosseous plasmacytoma. And extraosseous plasmacytoma is a soft tissue plasmacytoma. It's relatively rare. It often occurs in particularly the aerodigestive tract, and is highly curable. So it's very different to these other, particularly plasma cell myeloma, which is a very aggressive, and I'll come back to it, but the median survival of plasma cell myeloma now is about 7 years. So when we look at how we define myeloma or the plasma cell dyscrasias, is there's progressive myeloma, which is what we talk about in terms of myeloma that needs to be treated. Then it falls under a non-progressive myeloma, otherwise called smouldering or indolent. But the terminology we tend to use now is progressive myeloma, smouldering myeloma, and monoclonal gammopathy of undetermined significance, which I'll come to. Then these other 3 conditions, and I'm not going to really talk about them in much detail tonight. So people often get a lot of confusion around how to define myeloma and what's the issue around the paraprotein. The short of it is that you can develop myeloma with bony lesions or kidney failure or hypercalcemia with any level of immunoglobulin. So it can be 2 or it can be 50. We get concerned when the levels are greater than 30, and most patients who present with myeloma have levels of 30, 40, 50, 60. But it can occur at lower levels. So you can't ignore a paraprotein of 2 or 3. And one of our biggest challenges, how far do we investigate that? So to define myeloma, you really need to have a presence of plasma cells in the bone marrow. And so you do need to see at least 10% plasma cells in the marrow, and you need to have end organ damage, what we call myeloma-related tissue damage. So symptomatic myeloma or progressive myeloma is where you have the paraprotein. It can be at any level. You need to have a clone in the biopsy, and you need to have this end organ damage. Myeloma is always preceded by asymptomatic myeloma, and that can mean that you haven't got symptoms. And so these patients don't have the end organ damage. So there's a predecessor called monoclonal gammopathy of undetermined significance, where patients have a lower paraprotein, they don't have plasma cells in the bone marrow, they don't have any organ damage, and there's no evidence of other sort of blood disorders such as a lymphoma. So what do I mean by end organ damage? The best way to think of that is this so-called acronym called CRAB. Calcium levels increased, renal insufficiency, anemia, and bony lesions. And any of those CRAB criteria will define what is called symptomatic myeloma. You must have those to have symptomatic. If you don't, you have otherwise MGUS or asymptomatic myeloma. The thing that changes you from this to this is the presence of a paraprotein or more plasma cells. So how does myeloma present? These so-called CRAB features. So patients present with either, and the most common is bone pain, and it's typically the patient who's fallen off a bike and hurt their ribs, who've had chronic back pain, who spent years, months on and off going to see their chiropractor. Finally, the penny drops, and they think, oh, we better do a paraprotein. Importantly, people who have persistent back pain, and if there's an abnormality seen on the X-ray or the scan, a technetium bone scan, which looks at osteoblastic activity, so the laying down of bone will be often negative in myeloma. Myeloma is a disease of osteoclasts, in other words, taking up bone, and so when you've got only osteoclastic activity, a standard technetium bone scan will be negative. Patients, in the same reason, patients will often have a normal alkaline phosphatase, but they can have hypercalcemia. And when you've got someone with hypercalcemia, you need to think of multiple myeloma. If you do a PTH, the PTH may be relatively suppressed, or should be relatively suppressed, because of this hypercalcemia, which is due to the leaching out of the bones. The second most common presentation is renal impairment. Patients have an abnormal immune system, so they get infections, or relatively rarely they can present with a lump, such as a bony plasmacytoma, which can be causing pain, or a soft tissue plasmacytoma. So when we talk about progressive or symptomatic myeloma, the classic presentation is when patients have bone disease, we do a bone marrow and we see abnormal plasma cells, and we see a serum paraprotein more so than we see a urinary protein. But there is this condition which is called light chain disease, where in fact you don't see the intact immune globulin, but you only see free light chains either in the urine or in the blood. And I'll talk to you about that in a second. But classically, this concept of urine light chains, either kappa or lambda light chains, which is seen in the urine, is a common pickup. And this is so-called Bence-Jones protein. And you may well have heard that Bence-Jones was in the 1800s, and what he discovered was that if you took the urine and you could take this the urine with the protein in, you'd heat it, the protein would disappear, would no longer be seen, and then you'd cool it, and this protein sediment would come back as the temperature drops, so-called Bence-Jones protein. And so it's an important thing to remember that Bence-Jones protein is not picked up on a standard urine dipstick, that only picks up albumin. And so you can't test for Bence-Jones protein with a standard bedside urinary dipstick. You need to actually ask for the test. There's rarely this condition called non-secretory myeloma where you actually don't produce the paraprotein. That's rare. So we stage myeloma broadly by looking at three things now. We look at the albumin, we look at the beta-2 microglobulin, which is secreted off the plasma cells, and if the beta-2M is high, that makes it stage 3. I'm not going to go into the details except to say that that differentiates the outcome of people. And you can see here the median survival in ISS stage 1 here. This is a few years ago now, but you can see it's out to about 6 years. And then it drops back to less than 2 years if you have ISS stage 3. So you might often get asked the question, why might you have renal disease in myeloma? Well, one of the biggest problems in myeloma in presentation is that the light chains actually deposit in the as casts in the distal tubules. And so what normally happens in myeloma is, what normally happens in the kidneys is that at the proximal convoluted tubule, you normally get reabsorption of light chains. But what happens is when that is overcome by huge amounts of light chains, then you get you don't get this reabsorption, and you get co-precipitation with this particular protein called TAM horsefall protein in distal tubules, and this results in what's called cast nephropathy. So when you do a biopsy, you see this classic change. It's otherwise called myeloma kidney. But sometimes you can get glomerular disease, so it can otherwise called light chain deposition disease. You can get hypercalcemia, amyloid, cryoglobulins, and you can get a Fanconi's kidney problem. And also beware, contrast media itself can irritate the kidneys. Patients with myeloma, like with diabetes, are more susceptible to kidney disease with contrast media. So the initial workup for someone with myeloma is we do blood tests. We ultimately want to look at the paraprotein, which I'll come to. Doing protein electrophoresis. We look at the urine. Patients have a bone marrow to look at the morphology, look at the plasma cells. We do chromosomal studies. We do FISH studies to really try and identify the risks of these patients. We do imaging, and we do a skeletal survey, which I'll come back to in a second. So the laboratory tests. So if you want to look at these, have a look at the Myeloma Foundation website, because you'll see the myeloma guidelines, and you can go through these in a bit more detail. But basically in myeloma, you do the FPE. You look for so-called rouleau, which is this appearance of what we call coins on the side. And this is basically due to an elevated protein. So if you see rouleau in the peripheral blood, that you think of high protein. Now, you then go back and do a protein electrophoresis. That high proteins can be due to inflammatory. So you'll see rouleau if there's an inflammatory process. You'll see if there's polymyalgia. But also you're looking for a paraprotein. So rouleau in the peripheral blood, you might see a macrocytosis, and that can be due to the osmotic pressure on the red blood cells, causing an elevation in the MCV. ESR is elevated because that is due to the high protein in the blood. So anything that causes a high protein, such as inflammation, infection, which are acute phase reactants, or a paraprotein, will cause an elevation in the ESR. As I've mentioned, the patients can present with proteinuria that is often not much albumin, but predominantly light chains, and we look for BJP. They can get nephrotic if there is some element of glomerular damage, particularly, for example, if there's coexistent amyloidosis. We check their renal function, calcium, and as I've mentioned, their ALP phos can be normal. Sometimes it can spuriously lower the B12. So the paraproteins that we see most commonly in myeloma is the IgG, 70%, followed by IgA, followed by IgD, followed by light chains alone, 5%, non-secretory. One take-home message is that you should remember is an IgM paraprotein is extremely rare. IgM paraproteins very, very rarely cause myeloma. They're much more likely to cause, to be associated with low-grade lymphomas, particularly Waldenstrom's macroglobulinemia. IgE myeloma is very, very, very rare. So an elevated IgE is rarely associated with myeloma. We do a bone marrow because that's what we want to see. We want to see, we want to see these, what look like fried eggs, these plasma cells. These are all abnormal plasma cells of different shapes. You can see binucleate plasma cells here, and they have this clock-like appearance on the a clock-faced appearance on the nucleus, and you can see this these fried egg-looking cells. And so that's what we look at down the microscope. And we also want to do cytogenetics, which I'll come to. So imaging, skeletal survey. So a standard X-ray skeletal survey was often the standard, but that's now been replaced by a low-dose whole body CT scan, which is much quicker, much more accurate. I've told you about bone scans being negative. We often do MRIs of entire spine and pelvis looking for occult lesions, and sestamibi scans, which are mitochondrial scans or particularly PET scans, can be useful, although they're limited because they're not reimbursed for this indication. So you can see these lytic lesions, and you can see these classic lytic lesions in the skull. This is a huge one in the skull, but it's not uncommon to see these sorts of lytic lesions, these punched out lesions within the skull. And you can see these lesions which can deposit in the long bone and lead patients to develop fractures. So looking at the workup, I've told you about the imaging. We now use this low-dose body CT. Sometimes we'll use things like a PET scan. So this is the difference here. This is how we used to have to manage it. All of these scans are done at different times. This is a standard X-ray, but you can see here the differences between seeing these focal lesions on the MRI. So the MRI can be particularly helpful if we're looking for occult lesions. We're trying to sort out whether this patient has smoldering myeloma. But if someone comes in and you have a diagnosis with myeloma, the most important is that whole body CT scan. PET scans can help at picking metabolically active bony lesions, and this is the same patient with a PET scan, and this is with a sestamibi scan. But the PET scans are becoming more useful now to look at disease response. So this is an example of a whole body low dose CT. You can see that the lesion in there, the crush fracture. It will look at all sorts. It'll look at the vertebra. It'll look at the sternum and the abnormalities there. It'll also be able to look at the long bones. You don't really need to know the major prognostic markers in myeloma, except to say that I've mentioned that we use staging tests like beta-2 and albumin, and there's a variety of cytogenetic abnormalities which you don't need to know about that can predict a poorer outcome. And LDH is the other important predictor of poor outcome. So there are prognostic indices, and there's ways in which we can predict for high-risk myeloma depending on different cytogenetic abnormalities. It's not something that you need to worry about. So I'm just going to go back a bit just to sort of summarize a bit around what I've said. So the first thing to say is that myeloma happens over years and years. So monoclonal gammopathy of undetermined significance is where you develop this paraprotein. It can happen 10, 20 years earlier than the development of myeloma. So what happens is something initiates this event. This monoclonal protein appears. And then over time, the patients start to develop more plasma cells. And when they hit 10% plasma cells, it's called smoldering myeloma. But at that time, there's no end organ damage. There's no CRAB. And eventually they develop CRAB, which defines them as myeloma. And probably what's happening is that there's some primary genetic events that occur and then some secondary genetic events which push it along to the right-hand side. And so we're getting more and more understanding about the concepts of what's driving myeloma in terms of this deregulation of these primary genetic events. But often the biggest challenge that we face in general, that is faced by a GP and the patients that are referred to me, is what do you do with patients with monoclonal gammopathy? Because paraproteins in the blood increase with age. This is the prevalence in terms of percentage, and this is age. So if you look at a 70-year-old man, you can see here that about 5% of 70-year-old men have a monoclonal protein, an IgG or an IgA in their blood. What does that mean? And so our job is to work out, well, how do we investigate those patients with this so-called monoclonal gammopathy? And so this is the frequency. Most of them are IgG, IgA, or sometimes free light chains. And these are the sorts of conditions that can be associated with a monoclonal ban. Most of them are unknown, but you can only make this diagnosis if you've excluded these other conditions. And therefore, it's the patients we see that come into the clinic are, patients with a paraprotein of maybe 2 or 3 grams per litre. They may be 80 years old, and we have to say, well, how far are we going to investigate? Do they all get scans? Do they all get bone marrows? Clearly not. When if you look at the population here of 90-year-olds, you can see it's almost 10%. So if we were investigating 1 in 10 90-year-olds for myeloma, our health system would go bankrupt. So what happens here is that we have to decide, depending on size, if the paraprotein's present at the age of 40, you can see here that less than 40, it's less than 1%. So we're more likely to investigate these people for malignancy. So I won't go through all of the ways in which we do that, but really it's often common sense. How hard do you examine? So the testing that we do, it's important to understand protein electrophoresis, because fundamentally all it is that you take a plasma from the blood. You then, it's not serum, it's not anticoagulated, so it's plasma in the blood. It's just run over a gel and the proteins will move according to charge and molecular weight. And so here you can see this protein electrophoresis. This is albumin. This is the so-called alpha region, the beta region, and the gamma region. And this was simply by the person who first discovered this. He just said, I'm going back to the Greek, I'm going to call this what I see, the alpha region, this the beta region, and this the gamma region. And this is what is normal. And you can see this gamma region, and that predominantly is where all the immune globulins are. So if you look at this table over here, you can see these immune globulins. The predominant ones here are spaced in there. There are thousands of immune globulins here. In the beta region, you'll recognize that there are proteins, beta-1 lipoprotein, beta-1 macroglobulin, beta-2 microglobulin, but also sometimes particularly IgA and IgM paraproteins sit in this region. And then in the alpha region, you can see here these alpha globulins that you would recognize, including ferritin. So this is the normal protein electrophoresis. What happens when you order a standard protein electrophoresis is that they'll see this band here and they'll quantify it. And if this is albumin, it'll be about 35, that's normal. So this probably is about a 20 gram per litre band. And so that's being seen. You can actually see that there's a reduction there in normal immunoglobulins. And so then immunoelectrophoresis is done where you take the protein, you add an anti-gamma, an anti-alpha, or an anti-mu, and you can see here that there's co-precipitation. So this is an IgG. We also add an anti-kappa and an anti-lambda, and this protein here is called an IgG kappa. And so there's a number of causes of paraproteins, which are non-myeloma, and they typically are associated with either MGUS or another sort of lymphoma. Now, occasionally, myeloma can produce, instead of the intact immunoglobulin with the heavy chain and the light chain, which is like here, a heavy chain and a light chain, it can just produce light chains. And so this is important in non-secretory myeloma and amyloidosis, because previously we couldn't measure free light chains. We could only measure the intact immunoglobulin or free light chains in the urine. We couldn't detect it in the plasma. Now, by using special assays which detect abnormalities in what we call the cryptic site, we can pick up free light chains, which is very helpful for us diagnosing diseases such as amyloidosis. So MGUS is one of the more common things that you'll see. It's usually an IgG. Patients usually have a paraprotein. This is American, so that represents 15. So most of them are around this end, as opposed to once you are over 30, you can't have MGUS. It's called smoldering myeloma, but not that commonly in the 20s, but usually around 10 to 15 or a bit less. And what happens to these patients? Well, they eventually progress to something with time. About 10%, but you can broadly divide it up into 30% nothing happens, 30% of the time they progress to myeloma, and 30% of the time it just remains stable and doesn't change. And the risk really just goes up over time. There's a 10% risk of developing myeloma / lymphoma at 10 years, 20% at 20 years, etc. So it's about 1% per year. Now, what we do is that there's an app for everything. So by putting in certain things like the size of the protein, is it more or less than 15? Is it an IgG as opposed to the other? And what is the ratio of free light chains, which are being produced aberrantly? You can work out whether the patient has low or high risk of developing myeloma over time. What's their chance of progressing? And you can see here that this is 5% over 20 years, which is 0.5 risk, up to 58%, which is obviously much higher. So the next few minutes, I'm just going to talk about, give you a big overview of how you kill myeloma, how we treat it. And I'm not going to go through huge detail here, except to give you some big picture. So we can use chemotherapy. And 30 years ago, all we had was low-dose melphalan. We can try and stimulate T cells. We can try and induce apoptosis, or we can try and kill it like cracking an eggshell by using antibody-based treatment. And so, as I've mentioned, myeloma starts off as MGUS or smoldering. Then patients develop CRAB criteria. Once they develop symptoms, they need treatment. That will drive the protein down. So let's say the M protein was 70, like Our Lady at presentation. We drive it down, they go into a plateau. We want that plateau to go down as low as possible, because the closer it goes to zero, if it hits zero, the longer the remission will be. But typically what will happen is patients will go into some sort of plateau, then they'll relapse, sometime later. Hopefully, the longer the better. So, as I mentioned before, a standard transplant would typically give a plateau of around 3 to 4 years before the protein goes up. More treatment, plateau again, more until eventually they become refractory relapse. And really, our goal is to give new treatments, different ways of treating the disease, either T-cell therapy, stimulating the immune system, apoptosis, or antibodies. And so these are the drugs that we use. We use immunomodulatory drugs like thalidomide, lenalidomide, pomalidomide. Or we use the drugs that induce apoptosis, the proteasome inhibitors, such as bortezomib and carfilzomib, or we use monoclonal antibodies like the anti-CD38 antibodies daratumumab. When do we use them? We use them in induction, either pre-transplant or in the older patient instead of transplant. We use them in relapse disease and also in maintenance therapy. So the first of these novel non-chemo regimens was thalidomide, and it was derived really as we now know it acts predominantly through two mechanisms. It binds onto cereblon, which is what causes the fetal defects associated with thalidomide, but it binds onto cereblon and it affects both the T cells here and the tumor cells as well by altering both the T cell activation as well as certain survival genes within the myeloma. And this is true for all of the so-called immunomodulatory agents, which is thalidomide, lenalidomide, and pomalidomide. And when we had nothing for myeloma except chemo, this was back in 1999, this was great drug. We were seeing response rates of 30% in patients that had no other treatment options. And lots of patients had stabilization of their disease. And in fact, patients went for quite some time, given that they were previously chemotherapy refractory. But thalidomide has a number of side effects, particularly constipation, sleepiness, because it was developed as a sleeping tablet, and neuropathy. It also causes thrombosis. And so this is the incidence of the development of neuropathy. So you can only use thalidomide really for a short period of time before patients develop a peripheral neuropathy. Also, if you combine it with steroids or chemotherapy, sometimes up to 30% of patients can get DVT. So often we need to use anticoagulant prophylaxis in these patients. So after thalidomide, lenalidomide came along, and this was a derivative of thalidomide. And you can see here, this study was done, a lot of patients were treated here in Australia, in Melbourne, by Andrew and myself. And you can see here over dexamethasone, which was a standard of care, it substantially improved progression-free survival and subsequently overall survival. And then the drug called bortezomib, which is a proteasome inhibitor, it basically induces apoptosis and makes the cells commit suicide. And we saw responses in bortezomib of around 30%. So now when we see a patient with myeloma up front, we divide them up into transplant or non-transplant candidates. And if they're transplant candidates, they get induction treatment, then a transplant, and then often maintenance treatment. We rarely offer allogeneic transplants in myeloma. In the non-transplant candidates, we can choose between either lenalidomide or Velcade. And so again, I'd refer you to our guidelines to talk about how we decide treatment. But broadly speaking, if patients are under the age of 70, they usually get bortezomib plus lenalidomide induction for about 4 months. They then moved to a stem cell transplant with melphalan, and then they move on to lenalidomide maintenance. And they also get a bisphosphonate all through their treatment. Sorry. So without going through the guidelines in detail, basically what happens is if you have a newly diagnosed myeloma, you decide, are they a transplant candidate? If they are, they have 4 months of induction. We await response. They have their stem cells collected. They move on to transplant, and then they hopefully stay in remission for a few years, and then they relapse. If they're a non-transplant candidate, they have a number of options, but basically it's either a lenalidomide or a bortezomib-based approach. We used to use a lot of low-dose melphalan, We don't use it anymore because fundamentally it's stem cell toxic. It's affected by renal dysfunction, and in short, it's been replaced by these novel agents. Transplantation in myeloma does not cure anyone. It does improve progression-free survival, and it improves overall survival. If you don't use a transplant, overall survival is substantially reduced compared to standard chemotherapy. Nowadays, the other novel agents are improving, and one day transplantation will disappear. So we use transplants, autologous transplants, high-dose chemotherapy transplants for lymphoma and both non-Hodgkin's and Hodgkin's disease. And the principle behind that is that what you do is you give them some induction treatment, that you then mobilize their stem cells with growth factor plus or minus chemotherapy. You put them on an apheresis machine and you collect their stem cell product. You then give them high doses of chemotherapy for myeloma, that's melphalan. You reinfuse the stem cells, and then it takes about 10 to 14 days before the stem cells recover and the patients are reconstituted. So you have a stem cell collection, frozen down. The cells are then, the patient gets chemo, cells are thawed, and then reinfused back into the patient, and they reconstitute their bone marrow. And so, important concept here is that in lymphoma, we actually can cure patients. You can see a plateau in the curve compared to standard treatment. And this is non-Hodgkin's lymphoma. That's another study for non-Hodgkin's. And then in Hodgkin's disease, again, you can cure patients with standard treatment. These are very old slides because transplantation's been around for 30 years. But you'll see here in autologous transplantation for myeloma, we actually don't get that plateau. Patients relapse, but they do better than standard therapy. So although intensive therapy with transplant improves survival, it doesn't cure patients with myeloma like it does in lymphoma. But it does improve outcomes. So if you look at patients according to age here, when transplant came in the 90s, you can see how it's improved survival. So we often use maintenance treatment. So once a patient's had transplant, I'm not going to go through all the data, except to say that if you give patients lenalidomide, you improve progression-free survival and overall survival. Allografting, donation from other people, is not used routinely in myeloma. There is a graft versus myeloma effect, but there's a high mortality rate because patients are fundamentally immune suppressed. And in fact, there's studies that have shown that although there is a graft versus host disease effect where patients relapse less after an allograft, what happens is patients have a high mortality with a death rate. And when you look at the outcome, autografting is generally better. So for non-transplant candidates, patients over the age of 70, this is this group down here. Upfront treatment, I'm going to jump over this, is basically either Velcade or lenalidomide. So bortezomib or lenalidomide, the proteasome inhibitor versus lenalidomide. And one needs to consider a variety of things. Basically, bortezomib is a bit tougher to give. And so there's nice studies which have shown that if you give ongoing lenalidomide, you improve the outcome compared to melphalan-based therapies. And so the treatment principles really of myeloma are chemotherapy, following frontline treatment. When patients have relapsed to that frontline transplant, non-transplant, you just go back to the same drugs given in different ways. So if patients have had thalidomide, you've still got lenalidomide or pomalidomide. You've got bortezomib as frontline treatment. You can use carfilzomib, which is the next generation. And now we have monoclonal antibodies as we do in lymphoma. And there's a number of supportive treatments such as radiotherapy or bisphosphonates, but you need to be aware of osteonecrosis of the jaw. So there's no rules around relapse disease. We just depends on what patients have had up front. And sometimes patients will actually have a second transplant as per the case that I showed you before. So there's new drugs that are coming, carfilzomib, which is already approved in Australia, which is competing with the other proteasome inhibitors, and there's more monoclonal antibodies, and there's one about to be approved in Australia this month. So if you look at this pattern, this is where we're going to in the future, where there's going to be more monoclonal antibodies. There is going to be, hopefully, maybe more chemotherapy, more proteasome inhibitors, and then there's other targets of the cell signaling processes. That's been a big challenge in myeloma. There's the immunomodulatory agents trying to stimulate T cell activity. This is this group here, and hopefully more. And then ultimately the monoclonal antibodies, and not every monoclonal antibody is created equally. So we're going to see more of those. But one of the exciting areas is the combination of the daratumumab, lenalidomide, dexamethasone, which is this monoclonal antibody, where we're seeing, you can see here, you add a monoclonal antibody and you definitely improve outcome. So monoclonal antibodies are, like we see in lymphoma, going to become more standard of care. But using the immune system, and I'm not going to talk about it in any detail, but new drugs that can harness the immune system, such as CAR T cells, are under aggressive investigation in myeloma and really are the next generation. So I won't talk much about bone disease except to go back to what I said at the beginning, which is that it is an osteoclastic. This is a disease where it chews away at the bone marrow. The osteoblasts in terms of repair are impaired. And so using new drugs, using drugs such as the bisphosphonates are critical, but there's also drugs that affect rank ligands, such as denosumab, which is used in general osteoporosis, that is also being used in myeloma. But beware of osteonecrosis of the jaw, which occurs in any patients, breast cancer patients, or anyone who are getting any sort of bisphosphonate puts patients at risk, and we constantly need to consider it. So to finish off, I just want to go back to that case report that we had. This was this lady who had, initially she was treated with thalidomide, and then she went on to melphalan. Then then her disease came back. She was treated with bortezomib, the proteasome inhibitor. Then she relapsed and she got chemo. She relapsed again and she went on to lenalidomide, the immunomodulatory agent, and then later on has gone on to pomalidomide. And she had problems with carfilzomib, which is the proteasome inhibitor. And now she's getting daratumumab in combination with pomalidomide. So you can see how things have sort of evolved over the years in this lady. Ultimately, transplantation is still being used. Most people do not get second and third transplants. This is really because this lady has lived so long, but also now as we're getting these newer agents, we are improving the sort of upfront outcomes. So the key messages are imaging is important. We're improving the imaging in myeloma. Autografting with high-dose melphalan is still standard of care. Allografting is rarely used. We use targeted agents such as the IMiDs, which are standard therapies, thalidomide, lenalidomide, pomalidomide, proteasome inhibitors to induce apoptosis, and now monoclonal antibodies. And one needs to be aware that bisphosphonates are used throughout, but one of the toxicities is osteonecrosis. So I will leave that there and be happy to take any questions. And I'll see if I can stop sharing my screen.
Thanks, Miles. That was an awesome presentation. It's been really good, and I'm sure the students have really enjoyed it. Thanks again. So for questions, we're going to be using Slido for this. If anyone who wants to upvote the questions in Slido, they can do so now through the link. So the first question I have is there a hereditary aspect in multiple myeloma etiology? So would a relative having multiple myeloma increase the risk of someone else having it?
Yeah, so good question. The short of it is that there is a very small risk or association with a lot of blood cancers, which we do not understand. We often see patients who have CLL and we find out their Uncle Harry has myeloma or Auntie May has Hodgkin's disease. So there is a low-level increased incidence of other lymphoproliferative disorders, and we don't really understand that. It's actually extremely rare per se for myeloma to be in families, and so there isn't felt to be a underlying direct genetic risk. CLL and Waldenstrom's macroglobulinemia are the two blood disorders where there does seem to be a familial association.
Thank you. Another question is, why don't you treat it as MGUS or treat during MGUS?
Yeah, so I think so there's two answers to that question. One is that myeloma is not curable. And second, and so you can't treat, it's not like treating, say, early stage breast cancer. So ultimately those people will relapse. And so therefore you may be inducing drug resistance if you treat the patients too early. The second is that the second aspect is that most MGUSs do not develop. And so a lot of them are elderly. And even if a young patient, they may go for many, many years, 20 or 30 years with their monoclonal gammopathy. And the third aspect is that most of the drugs that we have some element of toxicity. So for example, lenalidomide has been associated with second primary malignancies, perhaps an increased incidence of other cancers. That's a lot of argument around that, whether that's true or you're just simply making people live longer. But possibly with monoclonal antibodies, where there's less toxicities, using those in earlier stage disease makes sense. In patients with high risk smouldering, in other words, where we believe that they're just on that brink from moving from smouldering to active myeloma, where they're just about to develop bony disease or kidney disease, there is actually evidence of coming in early with drugs like lenalidomide might be beneficial. So just to say that the difference between smouldering and active is it is a transition, it's a grey zone. And there are some people that we really talk about and sort of think, well, they've got MGUS, but they're almost smouldering. And the difference is that they're sort of destined eventually to become myeloma. So I think the short answer is that most people with MGUS never develop a problem, so we would be over-treating them.
Okay, thank you. So another question is, why do stem cell transplants, autotransplants, cure lymphoma but not multiple myeloma?
I wish we knew. Look, I think fundamentally it's got to do with the stem cell nature, the stemness of the malignancy. Look, going back to the 1980s, when people discovered that stem cell transplants really could cure some cancers, and the big cancers that it cures are things like lymphoma and germ cell tumours, testicular cancers, which are highly chemotherapy sensitive. But what happens is that there's a threshold effect. So for lymphoma, if we push the dose of chemo up, we are able to kill off the malignant cell. Not in everybody, but in most people. And we found that in lymphoma and Hodgkin's disease and testicular cancers. We don't find that sort of dose-response relationship in other cancers like renal cancer or breast cancer or whatever. So we've tended to find this in fundamentally what are curative cancers. So there's something about myeloma. I mean, it's probably the fact that these cells are there's a lot of cells that are relatively dormant, and therefore chemotherapy does not work as effectively on them. So for chemotherapy to work, you really need to have the bulk of the population in a non-dormant phase where the chemo can get in and get into the dividing cells.
Thank you. So if a patient has a suspected asymptomatic myeloma, should you do a complete workup, and what would be the most sensitive tests?
Yeah, so look, that is probably the biggest challenge, and it's not simple, because if I gave you a 35-year-old person with a paraprotein of 5 grams per litre, I'd be much more worried about that person than I would be an 85-year-old with the same level of paraprotein. So simply because of statistical risk. So really what you look at what we do is we look at the change in the paraprotein in elderly people. So anyone less than 50, we would generally look for we're looking for myeloma or lymphoma, and a whole body CT skeletal survey is the best test, because that will look for lytic lesions. But for example, if someone is, say, 45 and they've got a paraprotein of 20, and I do a whole body skeletal survey and I see no lytic lesions, I'd be thinking, maybe something's going on in the bone marrow. And I would think about doing an MRI of spine and pelvis, or a whole body MRI if that's available, and a bone marrow. So CT skeletal survey, MRI, bone marrow test are the tests that we think about. And it is a bit of an art as to which ones we choose, because it depends on the individual in front of you.
Thank you. And can you explain how myeloma modulates osteoblast activity to produce bone lesions?
Yeah, so look, it's complicated, but it's through a variety of mechanisms. There is direct activation there's a direct blocking and upsetting the imbalance between the natural osteoclastic and osteoblastic activity. So in bone remodeling, every time, and the reason that, people have encouraged to do exercise to prevent osteoporosis is to encourage that constant homeostasis of osteoclasts and osteoblasts balancing each other. So constant bone remodeling is really important for healthy bones. And so if you look at that principle, what happens though is that in myeloma, that is imbalanced. So you end up with it shifting to more towards osteoclasts. And that's through a variety of mechanisms, including local cytokine production, TNFs, but also antibodies. So there are blockages of important proteins such as osteoprotegrin, etc. So there's a whole lecture really on bone marrow homeostasis and myeloma, but ultimately it is aberrating that osteoblast process.
Thank you. And there's a question there about medical students and what they can do to get into hematology, but we've answered that question previously in the last seminar, Careers in Hematology. So Miles, you can answer it if you want, but it has been quite heavily addressed.
Oh yeah, no, look, my short answer is that I think it's the best specialty. So doing anything else is a waste of time if you want to be satisfied. But
Awesome.
the real answer is that I think, people choose their specialty by simply, negating others. But I think you need to, if you're thinking about going into hematology, it's about a long-term relationship with patients. And so that's why people do things like hematology or endocrinology, etc. You don't have a speed date with your patients like some specialties have. And hematology, but to go down the route of hematology, I mean, you just need good, broad, general experience, but you need to like looking after sick patients as well as patients for a long time.
Okay, we might leave questions there. Thanks everyone for your great questions. And thanks Miles so much for the amazing presentation. It was really interesting, and you were on time as well, which was fantastic. So thanks again.
I promise. But look, I think you get access to the slides, but if you're really interested and you want to know a bit more practically, go to the Myeloma Australia website, because there's videos that answer some of those questions in a very practical sense, a very patient-related sense, as well as the guidelines. And there's a whole series of guidelines. There's guidelines there of Waldenstrom's macroglobulinemia as well. So I encourage you to have a look at those, and you'll get everything you need.
Awesome.
Well, thanks for your attention. Thanks for the questions. Thanks, Gabrielle, and good luck with the rest of the series.
Thank you. Thanks everyone for coming tonight as well. We're planning a new event next month. So if you haven't, please get into the Facebook page and join ASSH for more details. Thanks everyone.